On behalf of the Patient Safety Authority, I'd like to welcome you to this web conference titled Infection Prevention and QAPI Reporting. My name is Katie Vivian, and I'll be your moderator for this program. Now I'd like to introduce our speaker for this webinar, JoAnn Adkins. JoAnn is a registered nurse and a senior infection preventionist for the Pennsylvania Patient Safety Authority. In her role at the authority, she works with healthcare facilities to improve patient safety through infection prevention initiatives. JoAnn has presented educational programs on infection prevention and control topics for hospitals, long-term care, and ambulatory surgery systems at the local, state, and national levels. She has authored several infection prevention and control articles and is published in the advisory. JoAnn is a graduate of the Reading Hospital School of Nursing and Eastern University. She is a fellow of the Association for Professionals in Infection Control and Epidemiology and is board certified in Infection Control and Epidemiology. JoAnn is a member of the Association for Professionals in Infection Control and Prevention, the Sigma Theta Tau International Nursing Honor Society, the Pennsylvania Association Directors of Nursing Administration Long-Term Care, and the Central Pennsylvania Association for Healthcare Quality. JoAnn, now I'll turn the program over to you.
Thank you, Katie, and welcome everyone who is attending the webinar. Today we're going to discuss infection prevention and QAPI reporting, or Quality Assurance Performance Improvement. If you work in long-term care, you've probably heard the acronym QAPI, which stands for Quality Assurance and Performance Improvement. And as part of the Affordable Care Act, it was a requirement that all skilled nursing centers develop QAPI programs. These requirements were also included in the Centers for Medicare and Medicaid Services, CMS, revised requirements of participation for nursing centers that was published in October of 2016. For ease of presenting, I'm going to use the acronym QAPI, even though we should be identifying it as quality assurance and process improvement. So here are our objectives for today's presentation. Identify the 5 elements of the Quality Assurance Process Improvement, or QAPI program. Discuss the importance of goal setting in infection prevention. List 3 potential process improvement projects, or PIPs, related to infection prevention, and describe how PA-PSRS analytics can assist in infection reporting at your QAPI committee. So what is QAPI, Quality Assurance and Process Improvement? Well, CMS, the Centers for Medicare and Medicaid, define it as a coordinated application of 2 mutually reinforcing aspects of a quality management system. It is the merger of these 2 approaches, the quality assurance and process improvement, and is a comprehensive approach to ensure high-quality care. The stated intentions of the QAPI regulations by CMS is to develop, implement, and maintain an effective, comprehensive, data-driven program that focuses on systems of care, outcomes of care, and quality of life. I know all of you in long-term care are well-versed in the Affordable Care Act, and it was Section 6120C that designated the importance of QAPI. The stated intention, as I said before, of the regulation is to improve care by focusing on systems and outcomes. And QAPI will take many nursing facilities into a new realm in quality because it is systematic, it is data-driven, and it's proactive to improve. And all of you are aware that November 28th of this year is when you needed to have coordination of your QAPI plan with incorporation of infection prevention. That infection prevention now needed to be part and reported out at quality assurance. Both quality assurance and performance improvement involve seeking and using information, but they do differ in key ways, and we're going to explain that. Quality assurance is the process of meeting quality standards and assuring that the care you provide reaches an acceptable level. It is a reactive, retrospective effort to examine why the facility failed to meet the standards. On the other hand, performance improvement is proactive. It's a continuous study of processes with the intent to prevent or decrease the likelihood of problems by identifying areas of opportunity and testing new approaches to fix underlying causes of persistent systemic problems. Performance improvement in nursing homes aims to improve processes involved in healthcare delivery and resident quality of life. So what's the guiding principle of QAPI? Well, the principle of QAPI aims for safety and high quality with all clinical interventions while emphasizing autonomy and choice for your residents in their daily life. It utilizes the best available evidence to define and measure goals. Nursing homes should have in place a written QAPI plan that adheres to these principles. And there are various activities of QAPI, but the activities involve members at all levels of your facility to identify the opportunities for improvement, address gaps in systems or processes, develop and implement an improvement or corrective plan, and continuously monitor the effectiveness of the interventions you put into place. I don't know if you're aware of it, but there are actually 5 elements to a successful QAPI program. Element 1 focuses on design and scope. Element 2 focuses on governance and leadership. Element 3 is feedback, data systems, and monitoring. Element 4 is your PIPs, your process improvement projects. And element 5 is analysis, systemic analysis and systemic action. So we're going to discuss these further. Element 1, the design and scope. Your QAPI program must be ongoing and comprehensive. It must address all services provided by your facility and extend to all departments within your facility, not just your nursing department. It addresses clinical care, quality of life issues, resident choice, and safe and effective care transitions. A robust QAPI program for Element 1 will utilize the best available evidence to define and measure goals. And you know how we always are talking about evidence-based practice. Well, you need to make sure that the evidence you're using and the guidelines you're using are the best practice out there. CMS requires facilities to develop a written QAPI plan that adheres to these principles. Element 2 is governance and leadership. The QAPI program must be developed with input and participation from facility staff, residents, and family members or patient representatives. It is the responsibility of leadership to confirm that the QAPI program is given the resources it needs to function. These resources include staff time for meetings, training of key staff is necessary, so ongoing functioning of the program continues even when there is staff turnover, and accountability to the changes that the program makes. We can put any policy into effect we want, but if we do not hold staff accountable, the policy resides in a book. Leadership also makes sure that staff accountability is balanced with a culture in which staff are not punished for errors and do not fear retaliation for reporting a quality concern. You want to make sure you have a non-punitive environment. Element 3 is feedback, data systems, and monitoring. It is never enough to create change solely for the sake of making a change. It has to be meaningful and useful. Various sources of data to monitor care and services must be utilized. And some examples of this various source data may be staff or resident surveys, admission or discharge data, internal compliance monitoring tools, and feedback from your resident council. Benchmarks should be set so success or failure can be monitored and must be monitored and reported. Element 3 also includes tracking and investigating all adverse events that happen within the facility, and then developing and monitoring an action plan that is implemented to prevent that reoccurrence. And that is talking about doing a root cause analysis. When we're speaking infection prevention, if you have an infection occur, you should be doing a root cause analysis with staff involved to see if you can identify any issues that could be improved upon. Performance element 4 is your PIPs, your performance improvement projects. These performance improvement projects are established based on topics the facility identifies as areas of concern or areas that need increased staff focus, opportunities for improvement. You should encourage all of your staff to participate in a PIP project that interests them. Staff of various levels, from your housekeepers or dietary aides to your nurses, bring different observations and ideas to the table, and all can have valuable input in a PIP project. You should also be encouraging staff to suggest an area where a PIP may offer improvement, or by doing a focused project may fine-tune an area that you're already doing satisfactory with, but could do better. Always select areas important and meaningful to the specific type and scope of services that are unique to your facility. Instead of just always doing a very generic PIP, it's important to look and see if you offer any unique services, such as ventilator care or short-term rehab, and focus a process improvement project on that specialty. Element 5 is systematic analysis and action. You need to adopt a systematic approach to determine when an in-depth analysis is needed to fully understand the problem that has occurred. Facilities should be able to demonstrate proficiency in doing a root cause analysis to identify the cause, prevent future events, and promote sustained improvement. The facility should strive for a goal of continual learning to stay abreast of current evidence-based solutions and to continuously improve your facility. So what are the components of a good QAPI program? Using data not only identifies your quality problem, but can also identify other opportunities for improvement, which you can then use to set priorities for action. No one ever wants to collect numbers just for the sake of collecting that data number and do nothing with them. When we talk infection prevention, we collect a tremendous amount of data, but then that data needs to be analyzed and used to improve resident outcomes. Another component is building on the residents' goals for health, quality of life, and daily activity, which is why it is important to speak with your residents and their family members. Another component is to bring meaningful resident and family voices into setting the goals for your facility and evaluating the progress towards those goals. Incorporating caregivers broadly in a shared QAPI mission also provides a voice for them. As I said before, different caregivers and staff from different departments may bring different observations and expertise to your project. Performance improvement teams need a specific charter or a specific focus, and then opportunities to improve that focus can be discussed. Root cause analysis is another component of a good QAPI program because that lets you get to the heart of the reason for a problem or issue that occurred. Another component is systematic change. Undertaking systemic change eliminates problems at their source. And then the final piece is to develop a feedback and monitoring system so that you have sustainability. Once you identify an issue, do your process improvement project, then you want to sustain and have continuous improvement. When you further develop your quality assurance performance improvement program, one big part of that is establishing your PIPs. But before we talk about the PIPs, it's important to understand measurement, quality measurement, risk assessment, and goal setting. So what is a quality measurement? A quality measurement in healthcare is the process of using data to evaluate the performance against recognized quality standards. To give you an example of that, I'm going to use antibiotic stewardship because many of you are aware of the need for long-term care facilities to have an antibiotic stewardship program in place. So when we're focused on antibiotic stewardship, quality measurements can be used to improve care by preventing the overuse, underuse, or misuse of antibiotics. Those measures will also identify what is working and not working. Those measures will help drive accountability, will measure and address disparities, and help your staff and prescribers make informed choices. When it comes to quality measurement, measuring the quality of health care within your facility is a necessary step in the process of improving the care that you deliver. Quality measures assess care across the entire continuum of the healthcare delivery system, from the level of an individual physician all the way up to insurance plans. And there are hundreds of different quality measures in healthcare, but they fall into four broad categories: structure, process, outcome, and patient experience. When we are talking about our QAPI program and infection prevention, we focus on process measures and outcome measures. A process measure is used to determine if the providers are following the protocol as established or defined in your program. It indicates what a provider does to maintain or improve health, either for healthy people or for those diagnosed with a certain condition. And these measures generally reflect accepted recommendations for best practice. An outcome measure is used to determine if the protocol you've put in place is having the desired effect. Outcome measures reflect the impact of the healthcare services or interventions on the health status of your resident. Outcome measures may seem to represent the gold standard when it comes to measuring quality, but the outcome is the result of multiple factors. So the easiest way to remember it is a process measure determines how often the service you're measuring occurred, and the outcome measure then evaluates if there was health improvement as a result of the care received. So where do we get these numbers from? Well, to establish your goals or your rates, then you need to have a numerator which measures what you're focusing on. It describes the target process, condition, event, or outcome that is expected for your targeted population, which in long-term care would be the residents within your facility. The denominator is the number of residents or occurrences during a defined time period who were at risk of or eligible for the Numerator event. So once QAPI is launched and sustained, there are many rewards. And the benefits of QAPI include competencies that equip you to solve quality problems and prevent their reoccurrence, competencies that allow you to seize opportunities to achieve new goals and improve care, fulfillment for caregivers as they become active partners in performance improvement, and as I said before, make sure you're encouraging and including staff in your projects because they all bring different expertise and observations to the table. And to me, the biggest benefit of QAPI is better care and better quality of life for your residents. So one of the things you need to do to set your goals for your performance improvement project is risk assess. And those of you that have spoken with me in the past or my colleagues know that risk assessment is a foundation of your facility's infection prevention plan. Conducting a risk assessment is a crucial task. By identifying your risks, compiling them into an assessment, you need to do more with that than just tucking it into the binder and saying, okay, that job is done. That's not the point of a risk assessment. The risk assessment serves as the basis for developing written goals and measurable objectives, especially for your infection control plan. In other words, this risk assessment is the foundation of your infection control and prevention plan. And the picture that I have showed there is just one of many examples of risk assessments that are available. But your risk assessment is to be done on an annual basis, or if your services change, because then the risks that are there for your residents may change. Once you have risk assessed, then you can set goals. So why is it important to set goals? Well, for any infection prevention or quality program, goals help clarify long-term vision, provide direction, help you focus your resources, provide clarity in decision-making, and provide motivation to work towards achieving those goals. I always am a fan of SMART goals. When you write goals, I try to make them be specific, measurable, achievable, realistic, and timely. When you think about the main focus of infection prevention, which is to protect the residents and others who enter your facility in a cost-effective manner, then setting goals is very important. Establishing goals is an integral part of establishing a high-performing quality program. Without clear metrics, you will not know where you have achieved success and where additional training or resources or focus may be required. So as I went through and did this presentation, best quality improvement projects change the culture in healthcare. So as I thought about quality improvement and also infection prevention, I wanted to provide some potential PIP projects or suggestions for you to think about within your own facility. These are ones that probably fall in line with issues you see on your infection prevention risk assessment. So the first one that I would suggest is antibiotic stewardship, because as you're all well aware, long-term care must have an antibiotic stewardship program in place. It is a CMS regulation, and what I would recommend is when you do your infection prevention risk assessment, look at your most frequent infection type and focus on one infection type initially, because the processes of antibiotic stewardship remain the same across multiple infection types. You may just need to do some tweaking of protocol and policy. But it is much easier to start with a common infection type, and when staff become comfortable with the processes and the protocols of antibiotic stewardship, it can then be moved on to a second infection type. So I wrote you some potential goals, and this is an example of goals focused on urinary tract infections, because we know urinary tract infections is probably the most common infection in long-term care, and is also one of the infections that are most often misdiagnosed or mistreated. So here's some potential goals for antibiotic stewardship as related to urinary tract infection. And you always set a short-term and a long-term goal, but as I said, remember the SMART goals. They need to be specific, measurable, achievable, realistic, and timely. I always focus my short-term goals as to be accomplished within 6 months. So as you see on this slide, I listed you process measures and outcome measures, and our short-term goal would be a 5% reduction in those combined process and outcome measures from your baseline. And then the long-term goal at the end of a year, if that's the time frame you choose, could be a 10% reduction in those process and outcome measures. And the measures I picked as process measures were focused in on asymptomatic bacteriuria, because as you read all of the evidence out there and the guidelines, we should not be culturing when a resident is asymptomatic, because we know most elderly people are colonized with bacteria in their bladder, so you would end up with a positive culture. And we should not be treating asymptomatic bacteriuria, because we would be treating colonization, which can lead to the development of drug resistance. So our process measures were targeted at asymptomatic bacteriuria, and I also put in there treating UTIs that don't meet PACER or McGear criteria, because they usually, for the most part, are your asymptomatic bacteriuria. And then if we do have success in decreasing those process measures, then we will see enhanced resident safety, because we have decreased our outcome measures, which is decreasing the percentage of new antibiotic orders for all urinary tract infections and decreasing the percentage of urine cultures performed. The second potential PIP project is focused on those of you that have device-associated infections. We have multiple different facility types in long-term care in Pennsylvania in our 700+ long-term care facilities, some of which see many more central lines, be they PIC catheters or dialysis catheters, or more urinary catheters, Foley catheters, because they may be dealing with neurogenic bladders from spinal cord injuries or neurological issues. So the second PIP I wrote was focused on device-associated infections. And the reason why we would focus on these is central line associated bloodstream infections result in thousands of deaths each year in the U.S. and add billions of dollars to cost to our healthcare delivery system. Foley catheter or catheter-associated urinary tract infections, and when we talk catheter-associated UTIs, we're talking a catheter that goes through the meatus. We are not talking suprapubic catheters. CAUTIs are possibly the most preventable healthcare-acquired infection and carry significant potential cost savings. And by following best practices, these infections are preventable. So that's why I wrote this up as a potential PIP project. And here would be your goals for this possible project. If we're focused in on Foley catheters, would be to reduce catheter-associated urinary tract infections from your baseline. And your baseline is what your infection rates are prior to implementing your change. If you're not sure of your baseline, I would look at 6 months of data, if you do have Foley catheters, and see what your infection rate is based on catheter days. And you're going to see the blanks in there because it would be, these goals would be set based on each individual facility's baseline. And my short-term goal would be a 20% reduction from baseline. So your short-term goal would take it, let's say if your CAUTI rate was I'm just making up numbers here. We'll say your rate was 8%, or 8 per 1,000 device days. Then you would want to see a 20% reduction, or you would want to take that down to 6. Your long-term goal would be a 50% reduction. So if we're looking at a rate of 8, then you would want to, your 50% reduction would be to reduce it from 8 per 1,000 device days to 4 per 1,000 device days. And the same thing would go into play if you were focused in on central line associated bloodstream infections. You would need to establish your baseline, and then short-term goal would be a 20% reduction from baseline with a long-term goal of a 50% reduction. And within your PIP project, some of the ways that you would want to accomplish that would be by providing education to staff on the prevention of CAUTIs or CLABSIS. Educate your staff on decreasing Foley catheter insertions to help decrease device days. Put into place the use of bundles and evidence-based practice guidelines for device care, for your Foley care or your central line care. And then any time that you had one of these infections occur, your QAPI team would do a root cause analysis of that infection to look for any potential issues on why the infection occurred and possible solutions to help prevent that infection from happening again. The third potential PIP project you know would be put in here from an infection preventionist, and that is hand hygiene compliance. Hand hygiene compliance should always be a goal for all facilities, irregardless of facility type. We always say, and evidence has proven, that the most important measure to prevent the spread of infection is high hand hygiene compliance. So we really need to monitor and make sure that we can improve the compliance among our healthcare workers. And it's also important to make sure your workers have knowledge on the importance of hand hygiene and they know the proper technique of hand hygiene, because this will reduce healthcare-associated infections. So how would you write a goal for that? Well, remember, with SMART goals, you want your goals to be achievable and realistic. So I know in infection prevention, we always strive for 100%, but we need to be realistic and achievable. Are you currently monitoring your hand hygiene compliance? If you are not, you need to be, and it needs to be appropriate monitoring. Use secret shoppers, as we call them. Tap into volunteers who may come into your facility to help you with this. Look to other departments such as your dietary aides or maybe environmental services to help with your hand hygiene monitoring. When we're talking hand hygiene monitoring, we want our compliance to increase. When we're talking infections, we want to decrease them in our goals. But when we're talking hand hygiene compliance, we want it to increase on your resident care departments as measured on monthly auditing. And your short-term goal I set is you want to reach 90%. Your long-term goal is you want to be 95% or better. And ideal would be to target 100%, but I don't know of anyone who is 100% compliant 100% of the time. So you can monitor and audit to make sure your staff are doing hand hygiene. And then the second goal you can audit is, are the products readily available to staff to perform hand hygiene? Are your soap dispensers filled? Are there paper towels available at the sinks? If you're using alcohol-based hand rub, are those dispensers full? And that can be audited monthly while you're doing your hand hygiene auditing. Same thing, you want a goal of at least 90% for your short-term goal and 95% for your long-term goal. And then the third thing you may want to audit is, are you providing visitors and residents with education on the importance of hand hygiene on at least an annual basis? And that can be measured on retrospective review. Is that education being provided annually? We are currently within influenza season, so if you have not recently done education on the importance of hand hygiene to staff and residents and visitors, I strongly encourage you to do that now. The next PIP project would be compliance with personal protective equipment. This is important because standard precautions and the use of personal protective equipment is part of your bloodborne pathogen exposure control plan for your facility. Are your staff compliant with wearing the appropriate PPE when needed? It may behoove you to set a PIP project on this to improve compliance among all your healthcare workers if you have lapses. And it also will help increase the knowledge of your staff on the proper technique for donning and doffing the PPE. And I want you to take a look at that picture because she's wearing a mask, a surgical mask, gloves, and goggles because we are in influenza season, and I'm just putting in a little notation there for you to remember that staff, as part of droplet precautions, must also protect their eyes, because the mucous membranes that line our eyes are capable of absorbing certain bacteria and viruses. So here's some potential goals related to PPE. You would monitor your compliance, and you wanted to increase on the resident care departments on monthly auditing. Is the appropriate PPE being utilized? Short-term goal 90% of the time, long-term goal 95% of the time. Another goal is, are the supplies readily available to staff? If staff need to go looking for PPE, their compliance will decrease. So is it readily available to them, and are you monitoring that on a monthly basis? And then another goal, a third goal, is do your staff receive education on donning and doffing of equipment annually and in the event of an outbreak? And I strongly encourage this education to also be a return demonstration. Let them dress for the occasion so you can see their technique. Are they putting on the PPE appropriately, the masks, the gloves, the gowns, if needed? And more importantly, do they know how to remove it safely to prevent contaminating themselves? Think back to the nurse who got Ebola in Texas. As they have done further research, they feel she contaminated herself removing her PPE. So it is important your staff know how to put it on, what is appropriate to be worn, and how to take it off. Another potential PIP project would be concerning environmental cleaning. A clean environment is extremely important to the prevention of infection. There are many studies out there that shows appropriate environmental cleaning helps reduce the incidence of healthcare-associated infections and enhance safety. And that's not only resident safety, it protects everyone who enters your facility from the potential transmission of a pathogenic organism. So how would we set goals for environmental cleaning? And this would be something that makes sure you have environmental cleaning staff on your PIP committee for the project. Well, they need to be compliant with hand hygiene and PPE usage. If they are going into a precautions room, a special precautions or transmission-based precaution room, they need to be wearing the appropriate PPE and performing hand hygiene so they are not transmitting that organism to somebody else. A big part is monitoring to make sure the cleaning agent they're using is mixed appropriately and being used in accordance with the manufacturer's recommendation for use. Do your environmental services staff know what the contact time is of the disinfectants they're using? And when we're talking contact time, the surface remains wet with that disinfectant. Do you audit, or does your housekeeping supervisory staff audit and ask their staff what the contact time is of the various agents they're using? Another thing you can monitor is that no food or drink is present on the housekeeping cart. They should never be there. There are studies, there have been instances of outbreaks of hepatitis A that has gone back, and when the CDC investigated, got traced back to the drinks that were present on the carts or at the desk. There should not be food or drink present on their cart. It is very easy for them in a hurry to maybe pick up what is a cleaning agent in a container as opposed to their drink. So that has happened before in other facilities. So that would be one goal that you could measure. Another PIP would be cleaning and disinfecting of equipment. Blood contamination to glucometers is the potential for bloodborne pathogen transmission. Non-critical medical equipment, such as your blood pressure cuffs, your stethoscopes, thermometers, they can be a fomite that will harbor and transmit pathogens. Non-critical medical equipment should be disinfected after each resident use. That includes your blood pressure cuffs. That includes your thermometers. And I'll tell you why. There was a study out there on non-critical device contamination, and what they found is that healthcare workers rarely disinfect between uses with different residents, and the predominant contaminant was staph. And when they looked at the staph, the contamination rates ranged from 25 to 100% of the time, with 2 to 32% of that staph being methicillin-resistant, MRSA. So it is important that your staff reduce the possibility of transmission from a contaminated non-critical device, so they need to disinfect them, and that should be strictly adhered to. So what are some potential goals for that? Well, look at your glucometers. Are they disinfected according to manufacturer instruction after each use if you do not have ones that are dedicated to each individual resident? And I would set a short-term goal at 90% and a long-term goal at 95%. Another thing you can look at for equipment cleaning and disinfection, and I put this one in here only from touring facilities, whether it was long-term care, acute care, or ambulatory care, are your medication carts free of debris and cleaned per policy? Do they get cleaned at all? Because when I lift up the pad or the towel on top of the cart, I see all kinds of things. So that was another possible goal. Somebody is auditing on a monthly basis to make sure those carts are free and clear of debris and cleaned according to your policy. And the final potential PIP I wrote up is influenza vaccination. We are in flu season. Hopefully this influenza season will not be as vicious as last year's season, but we all know vaccination is the single best way to protect yourself, your family, and your residents, and to provide a safe environment for everyone who enters your facility. So that's all done through education to healthcare workers and to monitor your vaccination rates. I know some of you, it is a condition of employment, but for others it is not, and you struggle with your percentage. So here's your goals. You want to increase your healthcare worker influenza rate from your previous season. So let's say last season you only had 68% of your staff vaccinated. Then you would set a short-term goal that maybe you want 80% of your employees vaccinated and a long-term goal of 90 or 95%. Same with your residents. Set a goal that increases short-term-wise by 20%, long-term-wise by 50%. And you could also have a goal focused on multi-drug-resistant organisms or Clostridium difficile if that is a problem within your facility. We know they're a problem across the continuum of healthcare and have a tremendous impact on resident safety, and the treatment options are often very limited and are very expensive, and also carry a high mortality rate. So if you are a facility that struggles with certain multi-drug resistant organisms, here would be a goal for you. You would want to look at your previous rate and use that as your baseline, and then decrease it by 20% per 1,000 resident days for short-term and 50% for a long-term goal. And this is one that you could collaborate with your environmental services on cleaning and disinfection, because that would impact your multi-drug resistant organism rate. You would also want to collaborate with pharmacy and physician on antibiotic stewardship, and also with your physicians on their antibiotic usage. So they can all tie in together. So how can we assist you? I want to do a quick polling question. Karen, please open the poll. Which method do you use to track and analyze the number and types of healthcare-acquired infections in your facility? Do you use the analytic reports and the graphics and pacers? Do you have separate spreadsheets and Excel that you can also then make into charts and graphs? Do you do an antibiotic list of your residents? Do you have corporate-based tools, or do you have no formal method of tracking and analyzing your HAIs? So I'm going to give you 30 seconds to a minute to answer that poll, and then we're going to discuss some ways that PA-PACERS can help you with that. So if you would, please take a few minutes and answer the poll for me. And Karen, when we get to a minute, you can close the poll if we have people answering. So we'll wait and see what it is. But if you're not aware, it is possible for long-term care facilities who report their infections into PA-PACERS to also use PACERS that has built-in analytic data tools to help you with your reporting at your QAPI committee. And Karen, I'm going to ask you to close the poll if you would, please. And we'll see what our answers are. But it is possible to use PACERS for that, and I'm going to give you some examples as we go on here. And it looks like most of you track using an Excel spreadsheet for your lists and then to analyze your data. So you may find that PACERS may be a little bit easier for you because you're already putting all of that data in there. If you are in PA-PACERS and you're in a long-term care facility, you're reporting your infections into here. And when you look at this, under the blue bar, you'll see analytic data tools. And when you click on that, in the drop-down box, select the event report data analysis. And you will have the ability with that data analysis to look at your infection types by table, by chart. This is an example of central line utilization rate from the data that you enter into PACERS, which is your resident days and your device days. And it will then give you your rate of your central line utilization that you can take to your QAPI committee. This is an example of the graphics that are available in PA-PACERS under the analytics. This is a urinary tract infection of a facility, and it's a fake facility that we made up. And what you see across the bottom in the dark blue line is the device rate of their urinary tract infection, and the lighter blue line is their device count. But more importantly, what is available in PA-PACERS is you are benchmarked by your peer group, and that is the other long-term care facilities in Pennsylvania that are similar in size to you. So you have the ability to make these graphs out of the data you've already entered in PACERS as part of Act 52 to make your reporting out of QAPI, and these can be copied then and used at your reporting. Or they can be combined on this one. I put these both on a PowerPoint presentation. I used the chart at the top that shows the actual catheter utilization rate, and then at the bottom copied in the table of the actual numbers. Because we always have those people who like numbers and people who like to see the quick snapshot. And one more thing that is available in PA-PACERS is the learning management system. So I want to know how many of you have ever used the Patient Safety Authority's LMS or learning management system for education. We have education modules in there, not only on PACERS reporting, but also on infection prevention that was developed by my colleague, Terry Lee Roberts, and they are excellent educational tools, and your staff will receive a CE for completing them. So please take a minute and just briefly answer this for me, because I'd like to know if people are using PACERS. And while you're answering that polling question, I'm going to show you a little bit about PA-PACERS. This is the learning management system. If you go into PACERS on the blue bar, you will see resources. If you scroll down that drop down, you will see the part that's highlighted here with the arrow, which is long-term care HAI reporting training. If you click on that, it will take you into the learning management system. If you're new to the learning management system, then you need to register. And if you save the link that comes up for the learning management system, you can share that with staff who do not have PACERS access, and they also can go in and register and complete the education in the learning management system. Karen, would you please close that poll, and we'll see how many people have actually used the LMS system. But when you click on the link in PACERS, it will open up this window into the learning management system that you can then register and complete the PACERS training, the education. This will then take you to this screen once you're registered, and on the left-hand side, you will see the learning catalog. When you click on the learning catalog, it will bring up all the available modules. And we have one there that I highlighted for PACERS Analytics, but then as you go scrolling down through, you will see ones on C. diff, on hand hygiene, on respiratory infections, and you will be awarded CE credit when you complete these learning management modules. And unfortunately, most of you have never used the learning management system. So I would highly encourage you to use that. I know we're running close on time. We have about 5 minutes for questions. So Katie, I'm going to turn this back over to you.
Thanks, JoAnn. That was a very informative presentation that contained valuable information everyone can use in their organization. That concludes our slide presentation portion of our program. Now we would like to begin our question and answer period. Okay, JoAnn, it looks like we have 1 or 2 questions here so far. The first one is, are nephrostomy tubes included in line listing?
A nephrostomy tube is not included when you're looking, I'm assuming they're talking about their device days for either central lines or catheters. That would not be included or counted as the urinary catheter. That would fall under the realm of the suprapubic, and it is not counted. It does not go through the meatus.
Okay. We have another question regarding hand hygiene. Is there a recommended form of hand hygiene for unresponsive patients? Just soap and water, or bathroom wipes, or alcohol-based wipes, or some different forms I can think of?
For an unresponsive patient who would not be feeding themselves or touching shared equipment or areas, then soap and water would be appropriate for them. I would perform hand hygiene with their daily bath, and when you're doing other care. My biggest concern when we're talking about educating residents and family members with hand hygiene are your residents who go into your group areas and your shared areas. Hand hygiene is important because it decreases the bioburden on your hands and decreases the potential of a resident picking up bacteria from surfaces and transmitting it to their own eyes, nose, or mouth, or transmitting it to other surfaces that can then be accessed by other members. So for those people that are non-responsive, and I'm going to assume are not touching other surfaces, then hand hygiene with soap and water or wipes would be appropriate for them.
Okay, we have another question. Our PIPs are limited to 30 days. This seems insufficient for infection control purposes. Do you have anything to add on that?
My comment would be, when you do a process improvement project, part of that is to change the culture within your facility so you can sustain the improvements you made. No one can change facility culture within 30 days. It takes much longer for a new improvement to become hardwired and become happy. So my opinion is 30 days would be very, very short to try to get that culture change to sustain that improvement. Because the whole goal of doing process improvement is you may see that initial improvement within the 30 days, but are you sustaining it and seeing that improvement continue 3, 6, 9, or a year out? And that's why it may be important to follow it for much longer than 30 days.
Okay, and the webinar will be ending soon, so we have time for one more question. And I will combine this question. Are PICC lines included for central lines? And there was another question, are dialysis catheters considered central lines?
Yes, any line that goes into one of the great vessels, be it a PICC line, which would be tunneled up into your subclavian, a dialysis catheter going into femoral, jugular, subclavian, they would both be included as central lines.
I would like to thank everyone for joining us today. This concludes our webinar.